question for you. Paul was the closest employee. Why not ask him for help?
Because you didn't seem like you wanted to run that. You just stood there. And if you would have made any effort, I would have helped them. So I thought you'd go get some comparable help. And you would have for some of the stores somebody else to come and help. The employees just standing there themselves and didn't do anything where really don't take any trust that he's going to if he doesn't take action right away.
Okay, any follow-up? Mr. Pollack?
Nothing further. I wish I thought of that question myself.
Okay. You may step down, sir. Thank you. All right, what do we have now?
Your Honor, we have a stipulation that we would like to notify the court on 30 days. Insofar as the medical bills that are applicable to this laws, we have agreed that plaintiff's medical bills growing out of this incident was $24,090.16.
Where's the exhibit? We have the exhibit. Is there a summary of their bills?
Yeah, I did a summary, and then counsel added in claim his co-pay.
She paid about $7,800, and that's how we come up to this number.
Which, okay, her total unadjusted medical bill is $16,502.
Yes, but she also paid $7,800, which came to $24,090. It's not on that summary. You could add it on.
Oh, you can add it on.
You mean have it typed up again, or?
If you have typed it up again, write it in.
Oh, yeah, let's write it in. If we could do that. That'd be great. Thank you.
I don't have that number, but it's the difference between the two. I've got a calculator to figure what it
We'll
was.
just do the total, and then we'll fill in the blank.
Where's my calculator? Where'd my calculator go? Oh. We don't have a separate calculator for the jury room?
Okay.
The battery's on the second one.
These days you can. I can't really ask them. We'll figure it out.
Get your phone.
Okay. Being done? You doing it? All right.
All right, who's the next witness?
Deposition of Dr. Pittsford, which is about an hour and a half to 2 hour deposition.
It's an easy 2 hours.
Easy. All right, why don't we start it and we'll take a break halfway through it and
Try to get it in.
try and get it in today?
There was one objection, and we worked that out.
Okay,
There's a couple miscellaneous ones in there. We'll just play through them.
just play through.
The one we worked out, Mr. Guzman's assistant's just going to take the audio down for like 7 or 8 lines, so it's only for a few seconds, and then she'll turn it up again, so we'll just keep it playing rather than stop it.
All right.
And that's with the additional amount. She paid the difference between 16 and 24,000.
Still loading up. I'll probably do it on my laptop faster. Can we do it on my laptop real quick?
You can do it quicker.
What are we doing? Just the difference
This is
between
the
both of
amount
these?
she paid. We have
Yes.
it on our...
Yes.
But,
Mhm.
but all you have to do is...
Subtract this from this?
subtract this from
Got it.
that.
Are you getting that into the doctor? Is that going into the doctor? Is that what we're doing?
Yes,
Yeah.
yes, sir.
Okay.
She'll be right back with you.
All right. Is she set up for the death?
As far as I know, Judge, yes.
Okay. What do I have to push on this thing for the death?
Plaintiff. Another one.
Okay.
You'll have that number in a minute, Your Honor.
Do you want us to just mark that as an exhibit then, a joint exhibit?
Why don't you start the debt and mark it,
Okay.
and when it comes in, we'll put it in.
Okay.
We're talking about the total amount of medical bills you're stipulating too? That's not just his bill, it's all the bills.
I know, but you're putting them in through the doctor, right?
No.
By agreement.
By agreement.
Yeah, so we do it at the beginning
I
of
can
it.
refer to them in his debt.
Yeah.
It's a reasonable, and, okay.
So here's a number, additional 7,580.
Guess you have to point that out to the jury.
So that's what we're proposing to just state it as a stipulation
Okay.
and save another 10 minutes.
The parties are going to stipulate.
You want to
it.
sign as a stipulated and sign our names to it?
Well, I'll just put it on the record.
We just state it.
All right.
Just state it on the record.
Okay.
Do it now.
All right, we go back to our microphones.
Okay. All right.
Thank you, Judge.
Thank you. All right. The parties have a stipulation as to the plaintiff's medical bills. Mr. Kuzman, do you have that stipulation?
Yes, I do, Your Honor. And the stipulation is that total medical bills that we stipulated to going on for treatment for her injury due to this fall was $24,090.16.
Okay. You have that exhibit, Mr.
Yes.
Oh, you want to mark the exhibit for the...
Yes, sir.
All right, do we have a deposition of the doctor? We ready to proceed with that? All right, ladies and gentlemen, we're going to play the deposition of the doctor. Watching on the monitor there. Make sure we have the sound up. Can you hear it okay? No. I'll put it with the volume. There's no volume.
And the inferior, the lower end, pointing at
Let's start it over. Can you hear it there?
Today is December 5, 2014. The time was approximately 14:48. The location is Lakeland Orthopedics and Sports Medicine, 9615 Tyoga Street, St. John, Indiana. My name is John Giannotti, video specialist in Lakeland Individual Services, located at 5013 Indiana. The case number is 45C011011CT 00189, titled Pacific Church, Crown Point, Indiana. Entitled Christy Klein and Timothy S. Klein, plaintiffs versus SPT, LLC. The witness is Dr. Keith Fisher. The video deposition is requested by Christy and Timothy Klein. Counsel, please identify yourselves as record.
Attorney Daniel C. Guzman, and I represent the plaintiffs Christy Klein and her husband Timothy Klein.
Good afternoon, Stephen Pollock for Stratton and so. And the two record, the Kleins are also present. Please swear your names.
Do solemnly swear that the testimony about to be the truth, the whole truth, and nothing but the truth.
Doctor, I'm Attorney Daniel C. Guzman, and I represent the patient Christy Klein and her husband Timothy Klein in regard to a claim for her injuries against Stratton Van Til as a result of a fall on the premises last August the 16th, 2009. After I have
For the jury.
curriculum 5 for purposes of jury clarification, it's a summary of all of your educational background and
various educational institutions you attended and among other things, correct?
Correct.
And how long have you been practicing treatment medicine?
I started residency in 1990 and I started practice in 1996.
Are you an MD or undergraduate MD or osteopath?
Osteopath.
What's the difference between an osteopath and a medical doctor?
The biggest difference really is where the underlying trainings came from. Allopath, which is an MD, is a branch of medicine that came from Europe through Canada to the United States. And that was the origins of medicine in the United States. And then a physician by the name of Andrew Taylor Still in Missouri started the osteopathic tradition, taking the principles of science of the day and adding manipulative medicine and a holistic approach to medicine, or to the patient. And so that's really where the two differ, is more of a holistic approach to medicine. The other way to say that is osteopathic medicine is the only branch of medicine that was founded in the United States.
Is it essentially a different approach in that you treat the whole picture?
That's the thought.
To the not necessarily just orthopedics.
Correct.
You graduated from what medical school?
Midwestern University, which was formerly Chicago Osteopath.
What year was that?
1990.
And then you've been practicing as an orthopedic surgeon.
Correct.
And what certifications do you have?
Board certified and recertified a number of years ago in orthopedic surgery.
And what did you do your intern?
I interned in Chicago at Chicago Osteopathic, and then I did my residency there as well. And then I went to the University of Illinois for a sports medicine fellowship, which is an extra year of arthroscopy and ligament reconstructive surgery.
In your practice, do you treat all parts of the body as with regard to bones and joints?
I do what we call the appendicular skeleton, which is the appendages, the arms and the legs. So I limit to shoulder work, elbows, wrists, hips, knees, and ankles. I do not do spine surgery.
How much familiarity and experience you have with knee surgeries?
Quite a bit. About half my practice is knees. And then the other bit is between the shoulders and hips. Then in residency and fellowship, that was knees were the primary focus.
Does that include ligaments and tendons as well?
Yes.
And also does that include meniscus tears?
Yes, sir.
At one point, excuse me, one other question before I leave that subject. Have you done meniscus surgeries?
Yes, sir.
What do you call that? Surgery?
Arthroscope, microscope, for short vernacular,
As opposed to more invasive type of procedures.
correct.
More modern approach is doing soaping where you can't, is that correct?
Yes, sir.
And a limited amount of entrance into the interior portion of the knee.
Yes.
As to torn meniscus, can you first explain what that is?
Certainly. Meniscus, there are two of them in the knee. One on the inside of the knee and one on the outside. They reside on the flat portion of the leg bone. and they act to bait the leg bone with the thigh bone. The thigh bone is curved. It has a cam effect, and that the round nature of the thigh bone would only have an articulation or only mate to the leg bone in a very small area. The meniscus helps spread out that area. So if the thigh bone is curved like my fist and the leg bone is flat like my palm, to put the two together, you would have a very small surface area. The meniscus acts like a gasket. I call it a gasket cartilage. It's a crescent-shaped, curved structure that it's triangular shaped in one dimension and crescent shaped in the other. So it lies on top of the flat leg bone and then cradles the thigh bone, increasing the surface area of the articulation between the thigh bone and the leg bone.
When you use the word articulation, does that mean the rubbing together of the two joints?
Yes. Yes.
So we want for it to be smooth and normal articulation to give the most amount of function to the upper thigh bone and the lower leg bone. Right.
That's correct.
And the meniscus then is pretty important.
Yes, sir.
Otherwise, if you don't have a meniscus or if it's injured, what are the results?
Advanced arthritis.
When a meniscus is torn, how does it get torn?
It's an injury that's sustained. There are several mechanisms of injury. Twisting injury, a translational injury, where the thigh bone, because it's nestled into the meniscus is nestled around the thigh bone, when there's a translatory force or rotatory force, either slides or rotates, the meniscus will separate. And you have to understand the meniscus is a fibrous tissue. It's a rubbery type tissue. It's made up of delicate fibers all woven together kind of like a basket. So its fibers all interknit together. But again, a basket's a really good analogy. And there's hoops, round semicircular hoops, and then there are vertical staying type fibers. So when the forces are applied, and you have to understand that the bigger anatomy of the meniscus is the posterior horn, the back side of the meniscus is tethered to the leg bone by small ligaments. They're called coronary ligaments. I didn't name them. I don't know why they call them that, but they wrap all the way around. The medial meniscus is tethered much more closely to the leg bone than is the outside of the lateral meniscus.
Or anteriorly?
The lateral meniscus has more tethering anteriorly. Inside and outside, the two meniscus are tethered to the leg bone. Now, the medial side, the inside, is tethered more tightly. It only moves about 6 millimeters, which is about 3/8 of an inch. The lateral meniscus moves about 12 millimeters, more like a half an inch, or slightly more. So there's a little bit of a translatory force there. So the lateral meniscus rarely gets torn. It does tear, but it doesn't tear to the same degree and extent that the medial side does. The inside edge tears more commonly because it's tethered. So you can see with it being tethered down, if there's that rotatory or translatory force, the meniscus feels that force, and those fibers will yield. If they yield enough, then you lose the integrity of the meniscus. And there are grades of meniscus tear. Grade 1 is intrasubstance tear, where you just have to kind of get a probe on there and feel that there's a separation of those fibers. Then there are other tears that have names associated with it: parabeak tear, bucket-handle tear, horizontal tear, vertical tears. So there's descriptors of the nature and type of tears that occur from this translatory or rotatory force.
When you use the word force, would that also be traumatic?
kinetic force?
Of course, force is just mass times acceleration. So it's what we call a weight multiplied times gravity, which is mass by definition, and then acceleration is a fall, which multiply the mass times gravity, which is 98 feet per second. You have the measure of force.
So we could put something falls upon the floor, for example.
Yes.
The method of treating that type of terror is what?
Let me just, it's not even really an objection. We're talking abstract in terms of risk. We're being more specific as to this patient, what that's what you do us, as opposed to
all right, let me think about
locations in the body. Thank you.
What did you first see the plaintiff?
I don't have any records in front of me, but I am
If you try, if you want to type those kinds of, I had to put in that suggestion to that question. Okay, on or about December the 13th of 2009.
Yes.
Okay. And when she first came to see you, did she have any complaints about her left knee?
Yes.
What were those complaints?
So she sustained an injury and continued to have discomfort. Went through a course of therapy and to no avail with continued pain in the left knee.
Did she give you a history of how she injured her knee?
No, I don't recall. I don't have any of that in front of me. My understanding is it was a slip and fall.
Okay. Did she mention she had a fall up on the premises of Stratford that supermarket?
Not that I know of.
You don't necessarily record those facts. Okay. But anyway, she gave you a history of having fallen and injured your knee.
Yes.
Correct. The course of treatment that you started with her after December the 14th, 2009 was what?
Usually therapy, trying to improve the muscle balance. When there's an injury to a knee and swelling occurs, which usually is part and parcel of the proceedings when the injury happens, there's a reflex that shuts down the muscles on the leg, primarily the quadricep muscle, which is the big muscle in front of the leg. It's just a reflex. It's an ancient reflex. It resides in the spinal cord. Our brains are big enough to override that, so you can still walk and function, but the muscle will remain weak. The muscles, there are four named muscles. That's what we call quadra, which is four, quad, four, and septate, which is Latin for heads, so four heads, four muscles. So these four muscles do several tasks. They flex the hip, they extend the knee. They also, there's a small muscle called the vastus medialis obliquus, or VMO for short, that in its name it's an oblique muscle that comes off at an angle and helps track the kneecap in the groove. The thigh bone, those two knuckles we spoke of, have a groove in between. That groove is called the trochlear groove. The trochlear groove is where the kneecap resides. When the muscles are diminished in strength, or imbalance, a disequilibrium or a difference in balance, that kneecap will ride awkwardly or differently in the trochlear groove, causing pain, continued swelling. I look at it as a vicious cycle where the swelling causes pain and weakness. The weakness causes more swelling and pain, and you have to break that cycle. So the goal is always to try to direct the therapy to balance the muscles, make the leg supple and strong, and then that diminishes that stop the cycle, the negative cycle, start a healthier cycle, and then diminish the discomfort.
When you first saw it on or about September the 9th of December the 14th of 2009, and I presume you examined it, correct?
Yes.
Did you come up with a preliminary diagnosis of various responsibility or
Yeah, I'm sure we did. I don't have that in front of me. Usually it's anterior knee pain. Let me just object to that. I'll show you your chart. Yeah, that would be helpful. I just don't.
In fact, the one market doesn't exhibit. It's my only copy. Actually, a copy of it. And you were kind enough to give us the last couple of visits, so I just attached those. But we will at some point attach them. So I think this initially 3 pages of bills and 28 pages of records, not counting the last 2 visits you just gave us. I do have the pages numbered in the lower right-hand corner. Okay. And I'll refer to that, I guess, as the defendant's exhibits. 10 for the markets. When we have only because that
off the record, they're saying there's a problem. You might have
All right, Doctor, you have before you a copy of your records with regard to the treatment of person client. And we look at your records so far as after her first visit on the 2nd, 14th, and 19th.
Yes, we have the 14 December visit of 09. And so to answer your questions more specifically, history does say that the initial event left knee, an initial evaluation left knee, that there was a fall in a grocery store on the 15th of August with a bent knee on the left. And it was our initial evaluation, and we reviewed an MRI that was obtained by a primary physician, and that was from the 3rd of September 2009. At that point, with the review of the MRI, there was clearly bursitis, which is a bursa is a sac of fluid that overlies a structure. It could be any structure. In this case, it happened to be the kneecap itself. It's called the prepatellar bursa, or the bursa in front of the patella. The bursa is just a sac of fluid that acts as a cushion for the skin to ride over the kneecap. So it's a normal structure, but it was inflamed based on the MRI. So that adds objective findings for the fall, the force that you spoke of earlier. Also tendinitis, and then to answer your question specifically, what our working diagnosis was, I was concerned about the inferior fat pad and the inferior pole of the patella. Now, the kneecap is not just a round button. It actually looks more like a bit of a teardrop. And the inferior, the lower end, is where a large tendon called the patellar tendon attaches. That's the inferior pole. Underneath that, in front of the knuckle of the thigh bone, is a very stout structural bit of fat, which we call the Hoffa. I don't know who Hoffa was, but it's called Hoffa's fat pad. The fat pad provides, it is functional. The analogy for that fat pad I draw for people is the fat on the palm of the hand and the sole of the feet. That's fat that gives us protection to be able to walk on our feet. It has ligaments in it, it has structure, it has function. The fat pad in front of the knee does the same thing. It has ligaments in it, provides structure, and then function. There are arteries that course through it. It acts to protect the knee when we're kneeling, bending. It protects the very important particular cartilage that underlies that.
But these don't have blood supplies.
The cartilage does not. The fat pad, of course, does.
So they're like a shopping floor.
That's a reasonable analogy. It does more than just that, but yeah, that's certainly a reasonable analogy.
Did you find any indication when you made your preliminary diagnosis of fat pad was dramatically damaged in any way?
Well, I based it based on the mechanism of injury and what I saw in the MRI. The MRI report shows that there's a soft tissue contusion in the anterior, the front part of the right. It says right knee, but it's an MRI of the left knee, so that's a misstatement by the radiologist. Of the knee joint, anterior patella and patellar tendon. So just as I said, the bursa and the tendon showed that there was a significant injury to a traumatic injury to that bottom pole and the bottom part of the patella, and then underlying that is the fat pad. So there was always that concern because these ligaments, when they tear, they scar. It becomes painful, and so that's something to be addressed in therapy. And you need to guide the therapy to be accurate and specific to a pathology. Just a sprained knee can mean to someone means something, but to an orthopedic surgeon means a whole other thing because we want to know specifically what was sprained. There are so many structures around the knee. In this setting, it was all in the front. It was the patellar tendon, the bursa, and then underlying that is the fat pad. And so with the deep pain that didn't resolve from the first bout of therapy, my concern was that there was issues that related to the fat pad.
And that made you suspicious of what?
Well, you're always concerned that there might be something else ligamentously or meniscus, something else going on. But even though the MRI didn't show it, they didn't. There's a certain criteria or level of pathology to make the definition or make the statement there's a meniscus tear, and you can have intrasubstance changes in the meniscus that technically would be a grade 1 tear, but a radiologist would never call that because it needs to penetrate either the superior or inferior surface of the meniscus to be and likely displaced, has to be separated. Understanding that an MRI is only about 15%, it's 85% accurate and specific, so 15% of the time it's flat wrong, which means that it says something's there that's not there, or it says something that's not there that is there. So we always continue to look and reevaluate as we go through. That's what we examine.
You find any other objective findings?
Most
What was her subject of complaint for that time?
left knee.
Did she indicate how long she had it, the intensity of it?
I have since the injury that was the fall on the 15th of March.
And then after you made your preliminary diagnosis, did you determine the course of treatment?
Yes, the plan at that point was to obtain a bone scan to look for a fat pad involvement or an occult fracture. Bone scan would show at this point an occult fracture. An occult fracture just means it's a fracture that doesn't show up on X-ray.
So that started you on the further inquiry as to what in fact was causing her discomfort.
Correct. So we saw her back then on the 28th of December, which was a couple weeks later. And reviewed the MRI, or the bone scan, and felt that the bone scan was negative. So that was a concern. And I was sure that ruled out the fracture. And I felt that we reviewed the MRI again, and showed that the MRI does show that there was some strain in the fat pad. That was my assessment on the 28th of December. And then now we're in a rule out mode.
Before we go any further, to the jury that may not understand what ruling out is.
Well, we were without anything more than tendinitis and bursitis. Now we have to start looking at other things that could cause him pain, substantial pain and dysfunction. And so we need to rule out other bits of pathology. The first step in that was the bone scan. The bone scan was to look for a fracture. We ruled out, precluded a fracture. So then the next thing was to look at Hoffa's fat pad, and I felt that there might be some fat pad impingement. The discomfort was described as achiness all the time. I was concerned that there might be some other underlying pathology because of
Like perhaps the meniscus.
certainly could be. That's high on the list. The ligaments were comfortable based on the MRI and that there was no ligament injury, but you could still have some meniscal pathology as well. And then the kind of the working diagnosis at that point was Hoffa's fat pad impingement, because I like it as a biting your cheek. When you bite your cheek, it hurts. And you keep biting it. It gets swollen, and then when you chew, it's lying right there next to your teeth, and you just, unfortunately, continue to bite it as you eat. Now, it takes some weeks and things finally settle down, and that goes away. But the fat pad may or may not go away. I see this in runners. Runners will get this fat pad impingement, gymnasts, wrestlers. When the fat pad gets scarred, then it becomes painful. And when things heal, they heal by contracting. So what that sets up is a scar and a contraction that is kind of like having a rocking your shoe, but it's in your knee. And that's a source of pain. We look at these as different pain sources. So, of course, we know based on the MRI that there was an bursitis and a tendinitis, and those generally will resolve with time and therapy. But the fact that the pain persisted, you need to start thinking now of other possibilities. One of which was the fat pad impingement, because that was the front of the knee, and you work to rule that out, rule it in, and obviously try conservative treatments. I've been in therapy for quite some time.
Were there any orthopedic tests or maneuverings that would have given you any indication whether it was positive or negative as to whether or not she had a fat pad injury or a meniscus?
Yeah, that's a good question. There's a couple of tests, rotation tests, compression tests. Just palpating and pushing on it is probably the most.
Did that cause your pain?
Yes.
So there was a relationship between you pressing in that area where you got fat pad over the meniscus, whether you were getting a sedation of pain.
Correct. And the facets of the kneecap have they have three flat spots, but two are actually articulated well on the thigh bone, and that was also
So do I understand what you're saying is that you've now ruled out or narrowed it down to either an injury to the meniscus or the fat pads or a combination thereof?
Yes.
And then what did you do thereafter?
The plan was to address the knee. We also, the recommendation at that point was we were going to just do some blood work, growth factor, C-rate, C-reactive protein, just to make sure that there was not some other underlying metabolic.
So we're still ruling out, in other words.
Correct.
All right.
And then, if those were all negative, then the thought would be to do what we consider a diagnostic scope.
Were they all negative?
Yes. Okay. I don't have them in front of me, but we did proceed to an arthroscopy.
But even though you had a prior MRI that did not indicate that she had a torn meniscus, that didn't deter you from going forward with further diagnosis or manipulation or tests or whatever else you had in mind.
Correct.
What was the next thing that you did?
So we did an arthroscopy on the 18th of March.
What is that?
An arthroscopy is this surgical intervention, surgery. It's done in the surgery center at the hospital. We make two small incisions about 3/8 of an inch long on both sides of the knee, into the knee with an arthroscope. And an arthroscope is a long, slender tube with a camera at the end. The camera projects the picture onto a screen adjacent to the operating table, and we can directly see the articulating surfaces, the meniscus, the ligaments, the fat pad, all of that. And as we indicated on the pre-op evaluation, that it was diagnostic and therapeutic. Diagnostic because we have a working sense of what the issues are, but we don't have definitive verification, and that's part of what the scope was all about, was to sort out where the pain source was.
Did it disclose anything to you?
It did. It's in the procedure was before the arthroscopy, we found a plica, which is a band of tissue that's naturally in the knee. A plica is a bit of tissue that was part of the knee when it was in separate compartments. When the knee is developed, when we're only about 2 inches big, literally this small, the knee the joints start to form. The knee is the largest joint in the body by size and volume. It starts as a series of compartments. Those compartments all coalesce into one big joint, one big space. Well, there's some remnants of those walls that are left, and that's a plica. A plica is just a band of tissue that was part of the knee when it was compartmentalized. These plica, when irritated, do the same thing that a fat pad impingement can do. They contract. Everything heals by contracting, getting tighter. So if you have this band of tissue that's overlying the knuckle of the thigh bone, that band of tissue, once it's injured, will start to contract. That contraction then makes more force where that kneecap, or that thigh bone, as it bends and straightens, as the knee bends and straightens, that band of tissue that's now getting tighter and tighter will rub over the knuckle of the thigh bone and cause discomfort.
Contraction means
tightening
up, swelling.
Yes, that's part of it.
Inflammation.
Yes, sir. That's what causes the contraction.
All of it consistent with previous trauma,
yes, sir.
In this case.
So we also saw a meniscus tear that was amenable to repair.
You noticed that on your first surgery on March 18th, 2010.
Yes, sir.
What part of the meniscus? Was it anterior? Was it posterior? Was it lateral?
The medial meniscus in the posterior horn of the medial meniscus.
And tell the jury in lay terms, if you can, what does that mean? What kind of damage is that?
So the meniscus is a crescent-shaped structure like we talked about, this, and the back is the posterior horn. There's a height, and it varies based on your size, the size of the person, the meniscus varies in size. There's some height and width. It looks like for lack of a better analogy, a crescent. It's shaped like a crescent, and it's thicker in the back and thinner in the front. And in the back, along the margin, the posterior margin, there is a rent or a separation. And we take a probe and we look at all of the structures with a thin wire probe, about the size of it's slightly larger than a paper clip, the wire, but it's long and it tapers down to just a fine point. And you feel under the structures. You can't physically feel them because the incisions you're making are only a half an inch wide, or a half an inch long, rather. But you put the camera on one side and you put this long wire probe on the other side, and you check all the surfaces. Yes, sir. And if there's a rent or a tear or a separation, that probe will drop into it, and you'll be able to feel that separation of those bundles that we talked about. Remember, there were the bundles of tissue, of cords, and if there's a separation of those cords, you can feel that with the probe. And we felt that at the time it was amenable to repair. In fact, obviously, when we go into a diagnostic arthroscopy, we try to manage any contingency. Certainly, meniscus repair is within the realm. If it's something much larger than that, we would proceed. But we knew that the ligaments were fine and the bones were fine based on the testing that we had done prior to this. So there is always a possibility of a meniscus tear. We're looking at the fat pad. We found a plica at issue. So you're trying to take care of all of the potential pain sources in one setting, one fell swoop, and that's what we did. We saw that there was a separation of the posterior one, the back side of that inside meniscus, and we repaired it with two suture tacks that are absorbable, they dissolve. We trephine, which is means that we pierce the meniscus with a needle to make it bleed, because you can improve the channels of healing, because the blood supply resides in the lining that surrounds the knee that the meniscus is attached to.
The meniscus also has nerve endings, like there's
nerve endings and blood supply, right?
To send a message to the brain that it's hurting.
Something's happening, yes.
So now you have it boiled down to essentially a tearing or a renting, I think is the term you use, of the meniscus of your left knee as a result of the surgery you did on March 18, 2010.
Correct.
Any other findings that we haven't talked about yet?
Just the plica, which is that band of tissue we talked about, but that's all.
After that orthoscopic surgery then?
Why don't we take a break at this point, since starting our topic. Ladies and gentlemen, we'll take a 10 or 15 minute break. So